G'day, mate. 40 here. We love our doctors, don't we, folks? I mean, we have the best doctors. We have the best healthcare in the whole world, don't we, folks? I mean, the best. I mean, we don't just love our doctors. We love our nurses too, because they're important. We love our hospitals, our Medicare and our Medicaid. We love our public health professionals and for everything they do to keep us safe. Thank you. Thank you. Okay, I'm reading this terrific book, Diagnosis, Therapy, and Evidence, Conundrums in Modern American Medicine. This book came out in 2009 by a medical historian and a medical sociologist. Just such a fun read. As you just go through all these fads in medicine, it reminds me of education. Like, I didn't really know what was going on when I was a little kid, but I did notice that every year there was like some new fad, blowing through my education. And so too with parenting, that you follow the news, there's like always some new fad of parenting, but there's no style of parenting that's shown to have statistically significant outcomes. And most of the things that we're told about, oh, this will reduce your cancer risk, or this will reduce your heart attack risk, there's very little evidence for it too. Most of the etiology, meaning the causes of chronic heart disease and cancer and almost all psychiatric medicine, we don't really have a clue. We don't have a clue, and yet there are all these authorities making great proclamations, and Americans have so much faith that the medical establishment is just going to dramatically improve the quality of life and the length of life, and now everything's getting medicalized. So old age, right? That's now an illness. So your bones, they naturally lose minerals as you get older. But now that's a disease. It's osteoporosis. Right? Everything's become a disease. You're feeling sad. Oh man, you have major depressive disorder. So we've got all these very specific categories of mental illness that have been the foundation of psychiatry since 1980, since the publication of DSM-3. And we don't have a clue what causes these diseases, and we have no objective tests for them, because the test for whether or not you have narcissistic personality disorder or multiple personality disorder, it largely relies on patient-reported symptoms, and individuals reporting their symptoms, or other people observing individuals and proclaiming that they have symptoms. It's not so scientific. Not so scientific. So yeah, we've got a problem with Afghan refugees. They've been a bit naughty. And frankly, I feel like the problem's with us, right? I think that that we failed. Like, we must have gone wrong, right? We let down our Afghan brothers, and if they're behaving badly, I think that's on us. So here's an article in the National Interest about the Afghan crime wave. All right, we love our health professionals, don't we, folks? We love our refugee resettlement agencies because they're important. I don't know about you. I would love to have another 100,000 Afghan refugees in this country as soon as possible. That would be amazing. So we have no objective tests. We have no blood tests, no physical tests for psychological illnesses or psychiatric illnesses. So we have all sorts of widely deployed medical therapies for which there's very little evidence. Like, this country and other countries were conducting hundreds of thousands of tonsillectomies, right? But by 1935 or so, there was an article in Scientific American saying there's no evidence that for the vast majority of tonsillectomies that they're doing any good. Yes, Lord, forgive our trespasses against our Afghan brothers, because any wrongs that they commit, I'm sure it is our fault. we must have gone over to Afghanistan and been racist and bigoted and sexist and homophobic and Islamophobic. So yeah, there are medicines that are effective, but many medicines and therapies are widespread in use despite evidence demonstrating their efficacy. There are all sorts of drugs that have been introduced and approved by the FDA with considerable fanfare, and then subsequently withdrawn because of adverse reactions. So over the past 50 years, we've had a steady decline in the number of GPs, general practitioners, or what PCPs they're now called in America, primary care physicians, and we've had this huge rise in specialists and internists. So specialists tend to be oriented towards surgery, right? You go to a back surgeon, he's going to look at your problems and he's going to say, "Oh, mate, you need some surgery." Right? So my father was a theologian, so he saw everything through a theological lens. So most medical specialties tend towards either surgery, use of fancy, expensive technology, and really dramatic interventions, because dramatic interventions are more exciting and it gives you more prestige and it makes you more money. So hysterectomies and oophorectomies, where they take out the ovaries, all right, causes decrease in lifespan. But doctors are doing these in the hundreds of thousands, these procedures, even though the net results for people on average are not so good. But doctors love getting into women's vaginas and ripping out ovaries. We've got spinal fusion surgery, very expensive for lower back pain. No evidence that this does any good, lots of evidence that this does a lot of bad. Do you know anyone who's just had one back surgery? I think everyone I know who's had one back surgery has then had follow-up surgeries. I don't know anyone who just goes in and get one back surgery. One back surgery always leads to multiple surgeries. It's like getting one tattoo. How many people do you know who only have one tattoo, rather they get that one tattoo and then they get more and more and more and more? And like getting breast implants. Do you know anyone who's just got like breast implants and that's it? Right? They've never had to go back in and touch things up. So spinal fusion surgery, we've had tens of thousands of spinal fusion surgeries. There's no evidence it's good for you, but it makes doctors lots of money. It has huge complication rates, much more than other types of back surgery. I'm reading from this terrific book, Diagnosis, Therapy, and Evidence, Conundrums in Modern American Medicine. So this is funny. So the Federal Agency for Healthcare Policy and Research noted that the bad results that come from a lot of back surgeries, in particular spinal fusion surgeries. And so they developed these evidence-based guidelines for managing acute back problems, and this panel recommended non-surgical approaches in most instances. So what happened? The North American Spine Society, the Union for Spine Doctors, then launched a lobbying campaign against the recommendations because the guidelines, as well as the research, showed that the use of a particular type of screws for this spinal fusion surgery had really bad results. But hey, those screws make me money. So because of the lobbying by spine surgeons and Medtronic is the manufacturer of these really dangerous screws. Because of the lobbying by spine surgeons and Medtronic, this federal agency received a 25% cut in its budget. And Congress removed its mandate to develop clinical guidelines. So despite the lack of evidence of efficacy, spinal fusion operations, they increased 77% between 1996 and 2001. And the efficacy of therapies for the overwhelming majority of mental illnesses is really weak, right? We've got these huge rates of drug treatment, right, just soaring, while the rates of psychotherapy have steadily declined. But there's no evidence that psychotropic medications are any more effective than interpersonal and cognitive psychotherapies, but maybe cheaper and easier. So what we have are changes in the organization and financing of mental health care that are dictating this massive amount of psychiatric drug prescriptions. It's not the success of the drug treatments that are dictating these changes. So aside from the most serious types of mental illness, the value of psychiatric medication does not much exceed the value of placebos. But now we've got like new classes of psychotropic drugs that are introduced with assertions that they are, greatly superior to the old classes of psychotropic drugs. Now we've got like second generation antipsychotic drugs. They're supposed to be more effective and have fewer adverse effects than first generation drugs, but there's no evidence for this. And there's no evidence that SSRIs have any advantages over Valium, over tranquilizers and older antidepressants, the meds that they superseded. So it's really the ability of a medication to generate profits. That's the primary determinant for how frequently it is used rather than its therapeutic benefits. So the lack of safe and effective treatments have not deterred the mental health industry from continually implementing new screening programs that strive to identify and then treat vast numbers of people who have not sought out mental health treatment on their own. So in 2003, we had the President's New Freedom Commission recommended that every teenager in America should be screened for signs of mental illness and suicidal tendencies. And then these screening programs were implemented in schools across the country. Because the more people you can screen, the more people you can diagnose, and then the more people you can medicate, and the more people you can make money off of, and the more people that you can dominate, and the more prestige you get. Yes, defend the Constitution. It defends you. So the rationale of these screening programs for suicidality among school kids is that like early detection of mental illness and early detection of depression and anxiety prevents not just impairments such as poor school performance and teenage pregnancy and substance abuse, but it screens for the development of mental illness later in life. But there's no evidence for this. Like there's no evidence that this widespread screening and subsequent treatment do anything towards these objectives. In fact, screening programs generate far more false positives than actual cases of mental disorders. And what they do is they create a vast amount of pathologizing of natural distress and sadness. So instead of people just being sad, now they've got a mental illness that needs medication. So this widespread enthusiasm for widespread screening programs for mental health for school kids completely exceeds the ability of detection and treatment to provide more benefits than problems for people identified with having these mental illnesses. And the same for screening for conditions such as prostate cancer, right? That's increasingly being questioned because a high proportion of detected tumors turn out to have benign outcomes, even when they're not discovered. So many of the etiological, that means causes, claims of medicine, the proliferation of these therapies of dubious efficacy conceal an even more significant problem. That is that we are medicalizing everyday life. All sorts of normal forms of distress is now being considered an illness. So now we no longer define aging as just a normal part of the human condition. Guys, aging is an illness. It's a disease. Like think about osteoporosis. I remember I went and got checked out and it's like, whoa, in my 30s I had some osteoporosis. Well, osteoporosis is a normal part of the human condition as you age, right? So once you hit bones cease growing after puberty, then they strengthen through a process of mineralization, but by about 40, your bones begin a gradual process of demineralization, and it lasts until you die. It's a normal part of life, and few people demineralize to the extent that fractures are unavoidable. But osteoporosis and osteopenia, scant bone, right? These are now a disease, right? I'm sure if you're over 30, I'm sure you have osteoporosis, dudes. You have a disease. And because you have disease, now you've got a proliferation of therapies. You've got all these dietary supplements, hormone replacement therapy. You've got drugs such as Fosamax from Merck and Actonel from Procter & Gamble. Now, how effective are these interventions? Not very, right? Virtually not at all. Now, what are the adverse side effects of these drugs? Pretty significant. So, osteopenia, scant bone, and things like osteoporosis, they're essentially a new age social construction. And they're propelled to their current status by aggressive marketing and vested interests by people who can get status and authority and money from convincing you that you've got this terrible disease. And now we've had a vast growth in the medicalizing of emotional life. Like, have you heard about the 5-HTT gene? It's a risk factor for depression, guys. You need to get screened. Right? We may have like 20% of the population with the HTT gene. But there's not much evidence that you really need to get screened for these things. We've got this massive proliferation of diagnoses, and we've got the use of numerical scales to expand and expand and expand the number of people who are suffering from some grave illness. And then we've got the medicalizing of all these normal phenomena of, normal rates of sadness. But hey, at least there are vast entrepreneurial opportunities. So the pharmaceutical industry essentially sponsors diseases and promotes drugs for diagnoses that at best are questionable and at worst, non-existent and harmful. So the pharmaceutical industry promotes medical education. It's essentially just a marketing strategy. And the pharmaceutical industry, of course, it has got very close ties to the medical profession. So doctors will prescribe drugs to a willing public, eager to believe the ads. Right? The FDA now allows direct to consumer marketing of medications, and people want to believe that taking this drug is just going to dramatically improve their life. So academic medicine holds substantial financial interests in pharmaceutical companies that then sponsor research within the same institution. So how do you get funding for science these days? By producing the kind of results that the funders want, right? There's very little funding for people to just go out and explore, right? All the funding comes from interested entities who want certain results. So that's why we can no longer trust science to govern itself. And we can't trust medicine. Is there any profession that we can currently trust to govern itself? So we have articles in medical journals typically prepared by drug company employees or by medical publishing companies hired by drug companies. We've got the most famous medical researchers are paid huge amounts of money and get listed as authors even when they have little to do with a study. Right? Faculty at leading academic institutions generally have ties to pharmaceutical companies that then fund their research, and they receive compensation from pharmaceutical companies for consulting and for speaking, and often get equity interests in these companies. And this problem, where is it most acute? It's most acute in psychiatry, all right? So prominent psychiatric researchers frequently don't disclose millions of dollars that they get in payments from pharmaceutical companies. So Marcia Engel, the former editor of the New England Journal of Medicine, notes it's absurd to look to investor-owned pharmaceutical companies for unbiased evaluations of their own products. But many academic investigators and their institutions pretend otherwise. Why? Because it is convenient and it is profitable for them to do so. Look Forward live streams is becoming a living art piece. 40, you need to interview somebody, anybody. I'm seriously worried about your mental state. You shine and heal while talking to others. Thank you. Can 40 do this in an acrylic box in Soho? I'll charge $100,000 per person. I am not on locals. Not yet. Okay. Is it time to talk about post-traumatic stress? Do you guys have post-traumatic stress disorder? So post-traumatic stress disorder is rooted in these like shocking, horrifying events that take otherwise normal, healthy people and turn them into people with mental health diseases, right? These events just come along and turn you into a zombie, bro. And you don't even have to be there for the event. You can just watch it on TV, or you can just go on Twitter and see a video of a beheading or a shooting or some Candace Owens commentary, and you can be traumatized, bros, and you might get PTSD, right? And then PTSD is like about the only psychiatric diagnosis that people want to have. People love to have that diagnosis. Why? Because there are all sorts of secondary gains. Do you know what secondary gains are? Those are the benefits that you get from claiming, a certain illness. So you can get monetary compensation for PTSD. You can get status. You can get extra special care. It's rare to find a psychiatric diagnosis that people like to have, but PTSD is about the only one. So then diagnoses like PTSD, right? You can join the bandwagon, guys. Join the moral crusade, right? And sign up for demands for redress, right? And you may not have suffered, but your ancestors suffered. So now you've got ancestral PTSD. So if you can claim that you've suffered from PTSD, then you can claim, compensation. On the other side, you've got claims of deception, malingering, and exploitation of the sick role. So it's difficult for doctors to remain neutral in these controversies. So where do they side? Well, it depends on the benefits of disease status and the sick role. So PTSD as a diagnosis emerged in the late 19th century. And since 1980, it has exploded in popularity. So PTSD is probably the fastest growing and most influential diagnosis in American psychiatry. So we've got this huge trauma industry. You got to catch the wave, guys. I mean, do you have stock in the trauma industry? It's just going up, 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 up. Right? You got to get on board with the trauma industry. You've got medical and mental health professionals. You've got grief counselors. You've got lawyers. You've got claimants. You've got a whole subculture responding to traumatic events by peddling proprietary workshops and proprietary, online programs that you got to sign up for. There are trade magazines. There are books. There are books, peddled to public safety, military school, hospital organizations. So the rate of publications about PTSD between 1980 and 2005 exceeded that of any other anxiety diagnosis. So trauma and the psychological consequences, this is a major stock in trade of daytime talk shows, TV documentaries, news programs. Like, we're all talking about PTSD. That's our reaction to trauma. So we've got a whole culture of trauma. So in human history, we've always had a lot of bad events like wars, violence, accidents, plagues, and victims have always, suffered from intense psychic disturbances. But until the latter decades of the 19th century, mental illness was limited to conditions resembling insanity. So when did we get PTSD essentially as a psychiatric diagnosis? Well, essentially developed from train wrecks. So once we started having train wrecks, then railroad companies could be held liable for injuries resulting from the shock and the trauma of train wrecks. So railway spine. That was the first diagnosis that captured the psychic consequence of disasters and emerged during the 1860s and 1870s when railway accidents became widespread. So, maybe you have railway spine, bro. So railway spine is characterized by patient reports of intense pain, loss of muscular control, paralysis, neurological problems, general health impairments, without any discoverable physical pathology. Whiplash. You look like you're suffering from whiplash, young man. So sufferers demand monetary compensation because their conditions have rendered them unable to resume their normal occupational, familial, and social activities. They may even have loss of consortium, right? They may no longer be able to make sweet or savage love to their spouse. So railway spine became a big issue in the 1860s and 70s. And at the time, most psychiatrists believed in hereditarian explanations. So they thought that psychiatric disorders only emerged in individuals who had inherited predispositions towards them. So after 1870, biological inheritance was widely accepted as the cause of mental illness. And it was the central precondition that led to mind breaking during accidental events. So people without these pre-existing susceptibilities who then developed psychological problems, well, they did not fit psychiatric theories, so they were to be regarded as malingerers. It's just like the deserving and the undeserving poor. That's the Victorian perspective on welfare. Now there is the deserving people who suffer from trauma deserve to be compensated, and then there are the undeserving. So prior to 1870, there was no psychiatric conception that would explain why previously normal people who were not predisposed could then develop mental illness after a severe life experience. So the initial debates over railway spine centered on whether physical trauma such as train wrecks could lead to a malfunctioning nervous system in the absence of any predisposition. So that was the debate. So there were theories then that physical shocks could produce mental illness. Then these theories were countered by other doctors who claimed that personal vulnerabilities and desires for monetary compensation lay behind claims of railway spine. So cynical. So whenever individuals stood to gain from a medical diagnosis, their motives became suspect. So doctors had a keen awareness of the advantages and disadvantages of granting victims of psychic trauma the benefits of the sick role. So many commentators said these injuries would remain chronic as long as they were reinforced by the possibility and the reception of compensation. So some claim the only differences between railway injuries and other injuries are that railway injuries you can get a payoff. So a man whose spine is concussed on a railway, he brings a legal action against the company and may get heavy compensation. But a man who falls from an apple tree and concusses his spine, well, there's no one that he can bring a lawsuit against. So railway spine was unlike almost all other medical diagnoses in that it led to monetary rewards. Having PTSD, it leads to sometimes monetary rewards and just cultural and life rewards. So there are all these secondary gains accruing from acknowledging and rewarding victims. And this has become a constant theme of our response to trauma-related diagnoses. So there are a lot of very cynical people who believe that psychic injuries stem chiefly from desires for compensation rather than from actual damage. So that cynical perspective is based on the argument that it's personal vulnerabilities and not traumatic events that are responsible for these problems. So you have two sharply contrasting schools with regard to trauma. So the first says that these kind of traumas are the result of actual physical traumatic events leading to damaged nervous systems. And then the second school says the injury lies in psychological susceptibilities to conditions such as hysteria and nervous weakness. So then after World War I, we got widespread shell shock. So there are many doctors and military officers and politicians who felt that shell shock was a product of cowardice and malingering, and it could only be overcome by harsh discipline. But military psychiatrists said no, it was the triggering events themselves, wartime experiences themselves, that led soldiers to develop these hysterical symptoms. And so there were some who say psychic weakness, and it's the desire to escape from the dangers of combat and the allure of a comfortable bed and a cushy pension, creates and perpetuates these symptoms of trauma like shell shock. So normal individuals naturally recover from trauma without long-term effects, but you have a minority of people who develop chronic disorders like long-term COVID, right? So most people who have shell shock or PTSD, they recover within a few weeks or a few months. Okay, so psychiatric casualty rates in the Vietnam War were remarkably low compared to previous conflicts. So one thing that's clear, the more time you spend in combat, the more likely you are to develop shell shock or PTSD, but most people recover naturally from this problem. Only a minority have ongoing PTSD or shell shock. Now, generally speaking, in the Vietnam War, psychiatric casualty rates were very low. So overall rates of mental breakdowns during the Vietnam War were only about 5 per 1,000 troops. So this compares to 37 per 1,000 troops in the Korean War and 70 per 1,000 troops during World War II. So this may be due to improved medical treatment in combat zones, maybe due to the expectations of quick recovery with better medical care, maybe it was the ready availability of alcohol and illegal drugs as a way of coping with the stresses of war. Maybe it was just the underreporting of psychiatric casualties. So when Vietnam veterans returned home to the United States had changed. So we had this dramatic social change. We got much more distrust of authority. We got widespread rejection of the war. We've got a highly politicized anti-war atmosphere. And it was a tiny group, a strong, vocal, and well-organized subculture of anti-war veterans emerged, most notably the Vietnam Veterans Against the War, VVAW. And this small group completely transformed the way we regarded PTSD. Just like it was a tiny group of psychiatrists at Washington University in St. Louis who were behind the DSM-3, which profoundly influenced all the succeeding DSMs. So too, it's just a small group of anti-war veterans who completely changed the way we understand PTSD. So PTSD was a very stark exception to the data-driven, causally agnostic descriptions of other diagnoses in the DSM-3. So we don't have any empirical studies showing how traumas produce specific symptoms. So the anti-war psychiatrists took advantage of the DSM-3, the revision, the Diagnostic and Statistical Manual, to aggressively promote veterans' interests, and that means promoting PTSD. And so they say we need this category. And so they were able to persuade the powers that be behind the DSM-3, hey, we got to adopt post-traumatic stress disorder. And so you had this new diagnosis in DSM-3. It had none of the trappings of other diagnoses. There were no field trials of criteria. There were no tests of reliability. There were no statistical analyses of data. So veterans advocates relied on anecdotes and mainly moral arguments that said, oh, if we don't include a PTSD diagnosis in this new DSM-3, that would be like blaming the victims for their misfortunes. Would Luke Ford be refused at the Australian border? Very possibly. So the veterans advocates were trying to get PTSD into DSM-3, and they had to persuade one other major psychiatrist to join them. Then they'd have enough to get the diagnosis. Right? So diagnoses aren't objective. Right? They're not based on blood tests. They're based on persuading your most important peers to get on board with this new diagnosis. And so these veterans advocates persuaded Nancy Andreasen, psychiatrist specialized in the treatment of burn victims. And they persuaded her that PTSD, you can't just limit it to war veterans, we can just apply it to all sorts of stressful situations. Victims of sexual violence, civilian disasters, accidents, survivors, right? Anyone who survived something. they may very well have PTSD. So what you have are these very well-organized, politically active veterans advocates, and the opposition to their theories was neither organized nor politically active. So you get the DSM-3 incorporating diagnosis of post-traumatic stress disorder that essentially just mirrored the recommendations of the anti-Vietnam War psychiatric group. And so this diagnosis requires recognizing the existence of outside stress that evokes significant mental illness in almost everyone, right? That's the criteria. Like, there are so traumas out there that are so horrible that pretty much everyone who goes through this trauma is going to become mentally ill. You know, these traumas, these external events, they're going to produce depression, anxiety, substance abuse. So the genesis of the PTSD diagnosis was political. It was a group of anti-Vietnam War advocates who pushed for inclusion of PTSD because they could use that as an authority to try to reduce the chances that America will go to war anymore. So then in the 1980s, we got this social movement that emphasized the widespread prevalence of repressed memories of childhood sexual abuse. So you had all these completely innocent people, the McMartin school trial, all these people running childcare centers that got accused of sexual abuse, and there was absolutely no evidence for it. But you had this widespread social movement saying, oh, people just have repressed memories of childhood sexual abuse, and we can recover these memories. So this crowd would say, well, look, the ordinary response to atrocities is to just banish them from our consciousness. So this repression of traumatic experience, is very different from the intense memories of Vietnam veterans who are able to easily recall their problems. So now you got the numbed responsiveness to the external world and the inability to recall important aspects of a trauma. That now indicates you got a mental illness of PTSD. So that means, much of the population now has PTSD. So according to one study, 61% of men and 51% of women have experienced at least one traumatic event. And so this study found that 10% of women and 5% of men have PTSD. So everyone who, saw 9/11 on TV or even heard about 9/11, they were widely expected to have experienced, trauma and to need grief counseling. We now, throughout the English-speaking world, we send out grief counselors whenever there's a traumatic event. So apparently, almost everyone was upset by 9/11. They were so upset that they essentially had PTSD. So if you had quite a bit of anger at Osama bin Laden, that means you have PTSD, bro. If you fear future harm to your family as a result of terrorism, you've got PTSD. If you got a fear of future terrorism, you got PTSD. If you're afraid of having more Afghan immigrants or more Islamic refugee immigrants, then, bro, you've got a mental illness. You've got PTSD. So what exactly did it mean to be exposed to 9/11? So it's not just the actual experience of being in the World Trade Center at the time of the attacks. Just watching events on TV is supposedly triggering PTSD. So, terrorist attacks, school shootings, natural disasters, other horrors are continually shared, broadcast on TV, social media. So virtually everyone is confronted with traumatic events on a regular basis. So the best indicator of getting PTSD from 9/11 was the extent that you watch TV news. Now, there were all these dire predictions after 9/11 that the 9/11 event would result in an enormous amount of psychological disorders, particularly PTSD. But in fact, these symptoms dropped precipitously soon after the attacks. So essentially, only about 1% of people developed PTSD. So by 6 months after the attack, only 0.6% had PTSD. And these are the people who are immediately experiencing 9/11. So that 99.5% of people quickly recover from such a traumatic event, calls into question, whether these traumas cause PTSD in the first place. So, traumatic exposure, right? That recedes in importance if you focus on individual susceptibilities. So the logic of the PTSD diagnosis, leaves a wide opening for those who want to emphasize individual vulnerability. So you can compare rates of pathology in groups that are exposed or unexposed to trauma to try to show the massive role of traumatic exposure in causing PTSD. But logically, unexposed groups cannot develop PTSD. Trauma exposure is a constant, it's not a variable. So the only possible comparison lies within a group that has been exposed to trauma. Glib Medley says, God forbid, the months after 9/11 in New York City were a good time to get laid because people were in survival mode. So less than 1% of people exposed to traumatic events develop PTSD. So why do some people develop PTSD and most people don't? So two psychologists say PTSD is best understood as a periodic expression of long-standing dispositions. So it depends upon individual susceptibility. So that's similar to earlier neurologists and psychiatrists who studied sufferers of railway spine, shell shock, combat neuroses, and traumatic experiences. The PTSD results from personal dispositions rather than from horrible external events. So poor individual coping styles, pre-existing anxiety, mood disorders, family histories of mental illness essentially predict who will develop PTSD. So PTSD remains the big exception to the overwhelming dominance of biological and psychological approaches to mental illness. So the core assumption of the trauma community is that there are these tragic events that can provoke PTSD in large proportions of the population. Now, there's no evidence for this, but there's a whole trauma industry pushing it. So the trauma industry is essentially an autonomous profession that studies and treats trauma with its own ideology, its own journals, its own conferences, its own training. We've got grief and trauma counselors, and they place their emphasis on exposure rather than vulnerability. And this crowd is firmly institutionalized in schools, in hospitals, in disaster relief organizations, and other establishments. So focusing on the vulnerability of the minority of exposed people contradicts the basic principle of the trauma community, which says that we must respond to catastrophes immediately and encompass entire populations, or they may develop these dire symptoms. So we've had this dramatic expansion of what situations count as traumatic. So now virtually the entire population can be viewed as vulnerable to developing PTSD, which means the entire population needs psychiatric help and medication. So the trauma community says that much of the population is going to develop PTSD unless we have mental health interventions that implemented immediately after disasters occur. So psychological debriefing is now mandatory in much of the English-speaking world after any disaster. There's this whole industry of grief counselors that sends therapists to natural disasters, to school shootings, to workplaces, wherever a stressful event has occurred. Because it's presumed that anyone who's experienced this disaster is going to be at risk. So we need to treat as many people as quickly as possible. Now, there's no evidence that this grief counseling and this treatment does any good. In fact, there's considerable evidence that it does more harm than good. So there's no evidence that these interventions relieve stress or prevent the emergence of subsequent PTSD. These single debriefing sessions that trauma and grief counselors provide have no efficacy, and they often produce detrimental effects when compared to no intervention. So generally speaking, people are better off getting zero grief counseling. So getting debriefed by mental health professionals tends to interfere with their own natural processing of traumatic events. It suggests to us that we're not capable of handling tragedies on our own, and it implies that we're going to be at risk if we don't submit to these interventions. And these prevention efforts often backfire. So school children who are given prevention training for dealing with earthquakes or possible shootings, they have much higher levels of distress than school children who don't have these kind of trainings. So a Cochrane review report concludes compulsory debriefing of victims of trauma should cease because there's no evidence that it does any good, and there's considerable evidence it does harm. But even though the evidence is clear that widespread debriefing after trauma does more harm than good, it's now mandatory in much of the English-speaking world. So emergency personnel in New York City were required to participate in mental health treatment after 9/11. Now, after the collapse of the investment bank Bear Stearns, the company called in grief counselors. Now, we've got the trauma industry. It's embedded in schools, in workplaces, in hospitals, in police and fire departments. It's embedded in the military. It's completely impervious to efforts to limit its intervention, even though the evidence shows that it's doing far more harm than good. So now the industry is spreading worldwide to dispense Western-style therapy to victims of natural disasters. We've got the military has undergone a vast change. So now it's expected by the Veterans Administration that veterans will commonly get PTSD. It's just inevitable. After you've been in combat, you'll get PTSD, that all soldiers are potential victims, and we need these short screening tools to indicate which soldiers are going to suffer. So there's the primary care PTSD screen. Uses just 4 items that ask you, do you suffer from intrusive thoughts? Do you suffer from emotional avoidance? Are you easily startled? And do you feel detached? Right? If you answer yes to any of those, bro, you got PTSD. So 27% of active soldiers, 35% of the National Guard and reserve soldiers are mental health risks. Now, almost all the soldiers who report PTSD symptoms are remarkably improved 6 months later. So for most people who go through trauma like being in combat, coming home and getting a job and getting a girl is usually, the most successful way of reintegrating into the community after military service. Get a job, get a girl. Get a job, get a girl. So there's no evidence that PTSD treatment does much good, and there's quite a bit of evidence PTSD treatment does harm. So it's social, cultural, and political factors that influence the degree of prominence given to the argument, it's exposure to traumatic events, or no, it's the argument that it's personal vulnerability that leads to problems. So ideologies that emphasize personal responsibility and individual agency, these perspectives dominate some eras, then other eras are dominated by explanations that focus on, external events. So environmental considerations dominate explanations at other times. Will Alexander technique cure PTSD? I'm sure that there are 1,000 different things that may help PTSD, including Alexander technique. and listening to the calming tones of my show. Is Luke still living off the Apricot Sky royalties? Yeah, one day a real rain will wash these stinking streets. Luke, mate, you have not read your Russian history. Stalin used psychiatry to label political dissidents as mentally ill. The only way out of PTSD is learned sociopathy or secondary sociopathy. Bye-bye.